Hello, everyone. My name is Dr. Edward Kaftarian. I'm a psychiatrist and I'm the CEO of Orbit Health Telepsychiatry. And I'm going to be talking to you today about youth suicide. So the disclosures that I want to tell you about, my disclosures are that I'm the chairman and CEO of Orbit Health Telepsychiatry. It's a company that provides mental health care to community mental health and also to the incarcerated. And I'm also a member of the American Psychiatric Association Telepsychiatry Committee. I'm the co-author of the American Psychiatric Association Telepsychiatry Guidelines. So that's a little bit about my background. And although I am the head of a telehealth company, I'm not going to be endorsing any specific telemedicine or telehealth products or services. I just want to tell you a little bit about youth suicide. I also want to tell you that there are secret codes that you're going to need to notice while I'm giving my talk. There are going to be 2 codes during the lecture. I want you to write them down, remember them, because the codes are needed for your CME credit, okay? So let's start with talking about suicide as it relates to the COVID-19 pandemic. There were obvious mental health repercussions of the pandemic. Everybody knows that, that's common sense. We were all isolated from other people and we got out of our routine, our social occupational routine. Now, that had a significant consequence on us as adults, but it also had an even greater impact for children, because children, of course, are going through development, and anything that is different is going to affect children more than it does adults. So during the COVID-19 pandemic, as mental health providers had predicted, there was an increase in emergency department visits due to suicide attempts and suicidal ideation. Ideation meaning thinking about suicide. There was a greater increase in girls and in those that are aged 12 to 17, and also an increase among boys aged 12 to 17. And so when we're talking about suicide, what does it look like? Well, suicide, somebody who is quote unquote suicidal is maybe they have suicidal thoughts, maybe they had serious thoughts, or just kind of passing, like passive ideation of wanting to be hit by a car versus active thoughts of taking an overdose. And some are very high in their intent to commit suicide, some are low, and then the mode of suicide attempt is either very lethal, like a gunshot, or not as lethal, like maybe an overdose of melatonin, something like that would be not as lethal of an attempt. And so that factors in to how quote unquote suicidal one is. Now, the suicide rates have significantly grown in recent decades, especially during the era between 1960s and 1990s. Suicide rates, especially among those that the younger population, children and adolescents, has grown significantly. And the reasons for that are varied. It could be a breakdown of the family unit, it could be societal pressures, complexity of life, it could be technology, it could be lots of things that have contributed to the rise in the suicide rates. And with the pandemic, as I was saying before, that isolation that children experienced, not going to school, not playing with their friends, the uncertainty of the situation, all of that plays a role in these young minds. And so not only did we have a chronic chronic escalation of suicide risk, but there was an acute escalation as well in the past couple of years. And that's borne out through studies that have been done showing that there had been more emergency department visits due to suicide attempts and ideation. Suicide is, well, I want to say it's common, but it's not common, meaning that it's a leading cause of death among children and adolescents, and suicide attempts are common, but actual suicide deaths as a number is low, and that makes it actually harder to predict. So suicide attempts are very common, maybe about 50 to 100 times more common than the actual death by suicide. So for every suicide, you'll have maybe 50 to 100 attempts. And then you'll have even more ideation, thoughts without attempts. Now, attempts are more common. If you had a suicidal ideation, you're more likely to attempt suicide, and if you're more likely to attempt suicide, if you've had suicide attempts, you're more likely to die by suicide. And so everything kind of precedes the other, and it's not that common for somebody to have suicidal thoughts and attempt suicide and die by suicide all in the first ideation. It usually is like a crescendo where it begins with ideations that lead to attempts that lead to ultimately suicide. So I'm going to point out the secret code, life, write that down. So children versus adolescents, that's an important distinction. Suicide attempts are actually, and completion of suicide is rare in prepubescence. After puberty, it becomes much more common, and adolescents are at a much higher risk. And let's talk a little bit about why that's the case. Why do you think adolescents are more likely to attempt and complete suicide than children? And when I say children, again, prepubescence, before age 11, 12, children are less likely to think about suicide and to complete suicide and attempt suicide. One is a cognitive ability. So children are less cognitively developed. Their intelligence is, of course, less than an adolescent who has whose brain is more developed. And so adolescents can think in the abstract a lot better than children. And so when you are able to think about the abstract, you think about your future, about the meaning of life. And if somebody is depressed and they are able to think through their future, even if it's a distorted thinking, they may be more likely to be hopeless, and they may more likely attempt suicide because of a feeling of that their life is not worth anything, that the meaning of life is confusing, doesn't make sense. Whereas younger children will not have that abstract thinking, and they may be depressed, they may feel hopeless, but they won't think to the next step of, what if I committed suicide? That would be a solution to my problems. The other factor that makes adolescents have a higher risk of completing suicide is because their mode of suicide will be more lethal. So I've examined children who were quote unquote suicidal, and their belief was that if they held their breath, they would die. And so that was their suicide attempt, that they would hold their breath. And they really thought that this would kill them. Whereas an adolescent who has a more, not a fully developed brain, but more toward a fully developed brain, will know that holding one's breath is not going to lead to death. And so those are the reasons why adolescents have a higher risk of suicide. And also because of pressures that you feel in adolescence. We all remember middle school and high school and the feeling of wanting to fit in, and just the feeling that you haven't really identified your identity and that's not fully formed and you're trying to make your way in the world. Children have less complicated pressures. Now, that all gets thrown out the window when you're talking about adverse childhood experiences where children are exposed to really traumatic things. And we'll talk a little bit more about that in this presentation. So gender factors. Attempts are more common just in general, regardless of whether we're talking about children, adolescents, or adults. Females are more likely to attempt suicide, whereas males are more likely to complete suicide. And that rings true for adolescents as well. So adolescent females are about twice as likely to attempt suicide, but adolescent males are about 3.5 times more likely to complete suicide, which means that the males have a much higher lethality of suicide attempt, and it typically involves guns, whether it's a gun against themselves, like finding a gun and killing themselves, or suicide by cop. So adolescent males as well as adult males, a more common suicide attempt modality would be to cause some sort of disruption that rises to the level of police engagement and then trying to make the police shoot them. And so that's obviously a very highly lethal mode of suicide. Whereas females, including adolescent females and adult females, will typically have an overdose of medication, and the lethality of that, and oftentimes it's Tylenol, and the lethality of that is variable. If you have a more lethal attempt with overdose, like, for example, drinking alcohol and using benzodiazepines or narcotic medications at the same time and overdosing them, that can be a very lethal combination. But oftentimes with females, it's impulsive. In males as well, it's impulsive. But when you have an impulsive overdose attempt, the person will grab whatever is available to them, whether or not this is something that is actually lethal. Like, for example, I've seen overdose attempts on melatonin. And so there was a high intent to kill themselves, but the lethality of that was not very high. Puberty is a big factor in female adolescents, and especially when the puberty does not match really like the chronological age of typical puberty. And it's been demonstrated that adolescents that reached puberty and had developed secondary sex characteristics ahead of their peers were much more likely to be depressed and also much higher risk of suicide. So that's something to consider as well. If somebody's puberty was like a premature one or one that was ahead of their classmates. So let's talk a little bit about gender identity, because transgender and non-binary individuals are at higher risk. And as you can see by this chart, transgender boys are much higher in considering suicide and attempting suicide. Non-binary and transgender girls and women are also at a much higher risk than cisgender boy and cisgender girl. So when we're talking about risk factors, we in the mental health community have pretty much been obsessed with suicide risk. And the reason for that is malpractice cases in behavioral health are mostly due to suicide. There can be other malpractice cases that are brought up for other reasons. For example, side effects of the medication, like tardive dyskinesia, or other cases where the treatment ended up harming the patient, or lack of treatment ended up harming the patient. But in most cases, when you're talking about big malpractice suits, it's because the person committed suicide and then they blame the behavioral health clinician. And so that is an extremely high liability for this profession. And therefore, for decades, we've been focused on how to prevent suicide. And of course, we want our patients to remain alive too. I mean, that's obviously the biggest factor. We don't want people to die. And I recall when I was a resident at Johns Hopkins, I remember I was a PGY2, and we were choosing our research projects. And I was talking with the emergency room, the professor who is the head of the emergency department at Johns Hopkins, and we were discussing potential research projects. And I floated the idea of, hey, how about if I try to identify the risk factors, the major risk factors in suicide, to help try to prevent suicide. And he laughed because I was so naive to think that, I could come up with a study that would identify the risk factors that were so elusive in the mental health community for so many decades. So I always think about that because I think of how difficult it is to prevent suicide. And one of the main reasons why suicide is so hard to predict is because on a case rate basis, it's actually low. So even though it's a really important cause of death, especially in children and adolescents, the actual rate of suicide in this country is somewhere, around 50, 60,000 suicides a year. And so when you talk about a population of 330 million people, identifying 50, 60,000 deaths, like predicting 50 to 60,000 deaths, is like a drop in the bucket. It's really it's like finding a needle in a haystack. It's really, really hard to do. But the problem is it has such incredible consequences that it is really important to try to prevent it, try to predict it, even if we can't really do that. So there are several categories of suicide risk factors, and I want to talk a little bit about predisposing and precipitating factors. A predisposing factor is something that makes it more likely for somebody to affect suicide. The first and foremost would be a psychiatric disorder. People who have had who've met criteria for a DSM diagnosis of a psychiatric condition or a psychological condition are much higher risk of suicide. And those who have actually had that diagnosis made, there's a difference between meeting criteria and actually having a diagnosis, right? So actually having a diagnosis increases your risk even further. So if you have a patient who has a diagnosis of a mood disorder or personality disorder or a conduct disorder, or those kind of conditions, those are going to lead to a higher risk of suicide. And depression being the highest, the biggest factor. Previous suicide attempts are going to be a big factor as well. There's a saying that the best predictor of future behavior is past behavior. So if somebody has attempted overdose in the past, that is the best predictor for their future behavior, which is another overdose. Family history is really important. We always ask that because a family history of a mood disorder and or suicidal behavior is a major risk factor. And let's talk about suicide. So if in the family, if somebody's parents committed suicide, they are much more likely to commit suicide themselves. And I oftentimes talk about this with my patients who may be thinking about suicide. I say, look, if you commit suicide, your children are much more likely to commit suicide. So it's not just about you and your feelings, it's also about how your actions affect other people. And you want to be very careful when you have that conversation, because you don't want to necessarily make the person feel like push the person away because you're guilting them so much. But at the same time, you do want to increase the stigma in their minds about suicide. And what I mean to say is, by saying increasing the stigma, is by making them understand that suicide is never an option. Suicide is never okay. It's never acceptable. Society is never okay with it. Your children will never be okay with it. And so that increases the stigma. That makes them more reluctant, or that makes them think twice about committing suicide. Now, somebody who has a death in the family from suicide, that increases their risk of suicide. But if it's a parent, that increases the risk even more. And then if it's the mother, that increases the suicide risk even more. So let's say a patient's mother died by suicide, they would be much more likely to commit suicide. And then if the patient's father died of suicide, that also increases it. But interestingly enough, not as much as if the mother committed suicide. In fact, the risk of suicide increases if the father commits suicide. It increases the same amount as if the father was accidentally died or unexpectedly died, just of natural causes or an accident of some other kind. So those are about equal. Whereas with the mother, if the mother commits suicide, that is much more likely to make the child commit suicide or lead to the child committing suicide being a factor, versus if the mother died by natural causes or some other accident. Another predisposing factor is a history of physical or sexual abuse, exposure to violence, and what we call adverse childhood experiences, ACE, adverse childhood experiences. So that's a term that you should be familiar with. And when you have a patient who's coming from a background that was traumatic, the adverse childhood experience could be physical trauma that they sustained or witnessed. It could be sexual or verbal traumas. It could be experiencing them themselves or seeing a sibling experience it. So violence in the home is a really important adverse childhood experience. Deaths in the family. It could be seeing drug use happen in the home. It could be seeing prostitution happen in the home, living in poverty, living in really unstable, like wartime situation, or in the ghetto, that kind of experience. Those are adverse childhood experiences, and each of those can be a factor to increase suicide risk, and it can be cumulative. So the more adverse childhood experiences, or ACEs, a child has, or even an adult had in childhood, the more likely that individual is to commit suicide. And so that's something that should be on your mind when a patient presents themselves with that background. That's why taking a biopsychosocial history is helpful and important. Precipitating factors are different than predisposing factors. So while predisposing factors kind of set up the risk level, the precipitating factors actually carry the person from having a baseline risk to actually attempting suicide. And so one of the precipitating factors for suicide, and again, the factor that brings them to an actual suicide attempt, would be access to means. So we often, when we're dealing with somebody that has suicidal thoughts, we often ask them if they have access to lethal means, such as a firearm. We say, do you have any guns in the home? Because if they do have guns in the home, that dramatically increases the risk that they will complete suicide. Is there alcohol or drug use? The reason for this as a precipitating factor is when you're using alcohol or drugs, you're not behaving in if you're intoxicated, you're not going to have the mental faculties that you would if you were sober. Alcohol in particular is disinhibiting. So if somebody has suicidal thoughts, those thoughts, they may be less inhibited and may be more likely to carry out a suicide attempt. Just think about it. If you're feeling hopeless and then you drink alcohol and you feel like, well, you know what, there's no inhibition there, you're going to attempt suicide at a higher likelihood than somebody who is sober. Exposure to suicide. So if you have seen somebody else, like seen somebody else commit suicide or discovered, you know, a body of somebody that has committed suicide, you are more likely to attempt suicide yourself. And I think it's helpful to explore that a little bit. Why is it that if somebody that you love has committed suicide, why are you more likely to commit suicide? Well, that's because the stigma has been reduced. The stigma of suicide has been reduced. In other words, the person who has completed suicide has effectively sent the message that suicide is an option. So if somebody's mother has committed suicide, then they may think, well, you know, if all else fails, I'll just commit suicide. That's my out. Whereas people who have not been exposed to that, it's not as present in their mind that that's an option, that's an exit path. Of course, social stress and isolation are an important precipitating factor. That's why we had a higher rate of suicide in adolescents during the pandemic. That's one of the reasons that we think led to higher rates of suicide attempts, because people were under greater amounts of stress and they were also very socially isolated. And we oftentimes we don't appreciate as much as we need to how important it is to be connected with people. And when you're not in person at work and going out into the community and going to the gym and going to restaurants with people, you are more at risk of being isolated. And so you need to take or ensure efforts to make sure that you are still connected with people. You can still work from home and feel connected. You just have to make more of an effort to do so. But children and adolescents, they don't have those coping mechanisms. They may not have the access to a car, you know, like they may be young, you know, too young to drive. And so they may not be able to actually get out there and connect with people. And so if they're isolated in their homes, especially during a pandemic, that's going to be a suicide risk factor. And then, of course, emotional and cognitive factors are also very important. If somebody is emotionally dysregulated, whether it's chronically or acutely, they have difficulty controlling their emotions, they are going to have a higher risk of suicide. And those who who have cognitive impairments, that may also be a risk factor for suicidal ideation. Now, people who have higher cognitive capacities, there are factors involved there too. For example, a really smart person is going to understand what it's going to take to kill themselves, whereas somebody who is not as cognitively advanced may attempt suicide in non-lethal ways, and we discussed that earlier. So prevention, as I said, it's very difficult. It's almost impossible to predict suicide, but it is still important to pay attention to risk factors and warning signs, not only because we believe that we can reduce the risk of suicide if we know what the risk factors are, but when we identify somebody that we think is high risk, one of the ways of reducing that risk is by preventing themselves from killing themselves through hospitalization or other means. Now, one good mnemonic that is often used is path warm. So is path warm, the letters of that spell out I for ideation, substance abuse, purposelessness, anxiety, feeling trapped, feeling hopeless, feeling withdrawn from friends, family, and society, feeling anger, recklessness, and mood changes. So those are all risk factors that have been identified by the Academy of Suicidology as factors that increase the risk of suicide. One of the factors that I want to pay special attention to is hopelessness. When somebody comes to me saying that they feel like they feel suicidal, they feel like they're having thoughts of suicide, I always want to hone in on the hopelessness aspect of it, because that is something that really is a big factor for one's desire to commit suicide. Because if you're hopeless about a situation, then being dead is a solution to you. And it's not a good solution, but it's a solution, and it's something that we should never accept as a solution. But if somebody is hopeless, that's a solution that's in their minds. But hopelessness often comes with clinical depression, and when you're depressed, you don't have the ability to see the hope, even if the hope is there. It's sort of like this is how I talk to patients about depression. I say that depression is like a cloud hanging over you, like a storm cloud or a rain cloud that's hanging over your brain, your mind. And when it's rainy, you feel like it's always going to be rainy, like those clouds will never dissipate. And that's what depression does. It makes you not understand that this feeling is not going to last forever. This feeling will go away. This feeling will come and go. And so if it's raining outside, we're not going to be hopeless and believe that it's always going to rain. We're going to understand that the rain is going to pass and the sun will come out. But people who are depressed will not understand that, because that depression holds on to your emotional centers of your brain, your amygdala, and the other deep centers of emotion in your brain. And that emotion is more powerful than the executive function of your brain. Decisions are made on an emotional basis, and not just decisions about suicide, but all decisions in life have an emotional component to it. And our emotions are a more primitive, although very powerful part of our brain. They're more primitive, and the more advanced parts of our brain, the human, more primate, like primate sort of and then Homo sapien parts of our brain, the frontal lobes, although they're more sophisticated, they are not more powerful than the emotional centers of our brain. That's why when we get angry, sometimes we do things that are just stupid that we would never do if we were not angry, because that anger takes control over our decision making. And so when somebody is hopeless, that feeling takes over. And so they need to know that this feeling will not always be there. So I hope that this is a pearl that you can use with your patients. Now, when we're screening for depression, we want to ask directly about suicidal thoughts, suicidal ideation. There's a common misconception that if you bring up suicide, you're more likely to give somebody the idea of suicide, and then they're more likely to kill themselves. That is definitely not true. So that is a misconception, and you want to ask about suicide. You want to say, but you want to be gentle about how you ask. You want to be a little sophisticated. And in children and adolescents, ideally, you would want to interview the patient with and without their parents being present. That's not always practical. Like in an emergency department setting, it's not always practical. In other settings, it's not always practical to have a separate interview with the patient versus the parents. But ideally, in a best case scenario, if you want to do a really in-depth evaluation, and there's time for that, I think that it is helpful to ask the patient directly, the adolescent directly, about their suicidal thoughts, and then pull the parent aside and ask them about the suicidal thoughts, because both parties may actually minimize their answers. So the child may not feel comfortable with you to tell you that they've been feeling suicidal thoughts, and then the parent, surprisingly, the parent sometimes minimizes the suicidal thoughts of their child because they don't want the child, for whatever reason, to be admitted to the hospital. That does happen. I'm not saying it happens very commonly, but yes, the parent may also minimize the chances of the suicidal thoughts. They may also inflate the situation too, and say that the child was suicidal when they weren't, and that can happen as well. It is helpful to have suicide, self-report screening tools such as the PHQ-9. The PHQ-9 is a 9-question screening for depression, and one of the questions is about suicide. So it is helpful to have those screens, but that's not going to be, the be all end all. You're going to have to do an examination as well and consider risk factors and get collateral information. Now, when you're asking about suicide, like I said, you have to be a little bit sophisticated about how you ask it. Some good questions you can ask are, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past few weeks, have you had thoughts about killing yourself? Have you ever tried to kill yourself? So those are ways where you can get at the same answer in different ways of asking it. And in fact, it sometimes takes a few different ways of asking the question to really get the patient to talk about suicide. And they may not ever talk to you about their suicidal thoughts. So the sophisticated approach of trying to get collateral information, ask the patient directly, ask their parent, look at the risk factors, look at the recent events, that is all very helpful in screening for suicidal thoughts. The emergency department evaluation and urgent evaluations, you want to emphasize the importance of treatment. Many people, especially those of lower socioeconomic classes, don't realize how serious it is. If somebody has attempted suicide, that is very serious and should be treated. Now, special attention should be given to the patient and their environment. So if somebody's coming to you and they're coming from a chaotic environment, sending them right back to that chaotic environment means you're sending them back to the risk factors, the predisposing and precipitating risk factors, as we talked about, that lead to a higher rate of suicide. And so when you have somebody that is in your emergency department or in your private practice office, and they've admitted to suicide because of a factor in their environment or a factor in that patient, you want to see what you can do about it. And there are static factors and dynamic factors. So a static factor is a factor that just will never change, okay? No matter what you do, that's always going to be there. So a static factor would be something like if the child attempted suicide, or if their parents attempted suicide. Basically, when that happens, they forever have a higher risk of suicide, and there's nothing you can do about that. You can help with treatment like psychotherapy and to try to reduce that as a risk factor, but you can never get rid of that risk factor. Let's say somebody has other risk factors that have to do with their medical condition. That can be static or dynamic. So if it's a chronic medical condition that will never go away, that will be something that's static. But a dynamic medical condition, dynamic means something that can change. And so a dynamic risk factor would be something like if somebody is being bullied at school, or somebody has a situation in the environment that can change. For example, like homelessness is a dynamic risk factor. If a child or adolescent is homeless, that's a big risk factor, but it's not a static risk factor. It's something that can change. And now restraints are sometimes needed in order to keep somebody from killing themselves. But I would say that these days, we rarely do restraints, because restraints are not therapeutic. To bind somebody's hands and feet and not let them move is really intrusive and harms the therapeutic relationship, or has the potential to harm the therapeutic relationship. And so we only use that as a last resort if somebody is really actively trying to kill themselves, like in the moment, they're reaching for something to kill themselves, and the only way you can stop them is by restraining them, then you do that. But otherwise, it's not really a useful means to reduce suicide risk. Observation is obviously very important. It's not on this slide here, but if somebody has attempted or is thinking about suicide, there oftentimes will do a one-to-one observer. And then when you want to stop the observation, you have to have a good reason to do so. Like the patient has calmed down, their suicidal thoughts are less strong, there's a treatment plan in place, the patient has bought into the treatment plan or is cooperative. These are some of the things that can make you think that observation may be less needed, but that's a clinical judgment call. So in the planning around how to mitigate suicide risk in the emergency department specifically, and in other environments, having mental health training of the staff is really important. Access to medical records, so you can plan on what is going to be needed for this patient, what they've gone through, what some of the risk factors are, and some of the biopsychosocial factors. That's important. You want to develop the crisis plan, and that's very important too. We'll talk a little bit more about that on a future slide. And so when you're assessing risk of suicide, there are multiple things that you want to think about. You want to think about the content and the chronicity of the suicidal thoughts. So how strong are they? Is it just in passing, or do they think about it all the time? What is the method that they want to use, the lethality of that method, the intent that they have? Almost more people than not, most people have at one point or another thought about suicide. Even my audience here, more than half of you have at one point thought about suicide. And usually it's just in passing, like, oh, what if I killed myself? And usually it's just very brief and fleeting. But if somebody comes to you and they have sustained suicidal thoughts, then that's something that should be an important factor for you to consider. The existence of a suicide plan, that is also very important. We always ask, when somebody tells us they have suicidal thoughts, we always ask, well, do you have a plan? Because if you have a plan, that shows a higher degree of intent. And then the nature of the plan determines its lethality. Like, do you have a plan to go overdose on melatonin, or do you have a plan to go get your father's gun and shoot yourself? And do you have access to the means described in the plan? So do you have access to your father's gun? What is your intent? Like, do you definitely want to kill? I've had patients tell me, no matter what I do, I'm going to kill whatever I do as the doctor, they're going to kill themselves. They've told me that. And so what that meant was, I need to get them to calm down. I need to hospitalize them potentially and get them beyond that rain cloud that's hanging over their head, so that they won't be as intent on killing themselves. And then, of course, stressors, pain, behavioral problems, social supports, all of that factors into the suicide risk. You want to obtain collateral information when you can, because you can't always count on the patient telling you the truth. Even sometimes you can't always count on the parent telling the truth. The parent might tell the truth, but not even know. It could be a parent who only has the child once a month for a day, and they don't necessarily know what's going on in the child's life. Maybe they do, maybe they don't. So that is all something that you need to consider. And as you can see, this is not a science, it's an art. We can take the science, and use that as helping us, give us resources, but it's also going to be the art of putting it all together and the clinical judgment. Seeing people like this for an entire career makes me more skilled than somebody who has not seen patients like this. And it's really important that if you don't have experience seeing patients that have suicidal thoughts, that you bring in other people. You make a referral to a psychiatrist or psychologist. You get them further assessed in an emergency department. So these are all very important things to do if you're in primary care dealing with suicide risk. Okay, so medical evaluation, it's important that you do a physical exam and laboratory studies to determine the nature of the medical condition of the patient, because that can play into their mental health condition. And then the psychiatric evaluation, like I said, identify any predisposing or precipitating factors, do a thorough mental status examination, a risk assessment, and then recommend the level of care. So those are all parts of the psychiatric evaluation. And if you are not a psychiatrist or a psychologist, you should probably get somebody to help you with this. Management, there's a decision between outpatient versus inpatient hospitalization, voluntary versus involuntary. With children, it's the whole issue of voluntary admission is complicated. A child cannot necessarily consent to the treatment. They can assent to it, meaning they can agree to it and go along with it, but ultimately the parent or guardian is going to be the one that authorizes whether the child can be hospitalized. And depending on the state that you're in, if a parent disagrees with the hospitalization, there are legal means to hospitalize the patient over the objections of the parents. But that is a high standard, that's a high bar, and you'd have to be knowledgeable in the rules around that. So having access to an expert to talk you through that would be helpful. Psychotherapy is helpful, and pharmacotherapy, medications are also helpful. They're not going to stop a suicide attempt. They're going to help prevent somebody from, they're going to help mitigate the predisposing factors and the precipitating factors. So like if I give somebody an antidepressant after a suicide attempt, that's not going to necessarily prevent them from killing themselves, but it will address an underlying condition such as depression, which will lead to suicidal ideation. So if you can treat the underlying condition with medications or therapy, then you've addressed to some degree their suicide risk. So finishing up here, there are plenty of resources, youth.gov, suicidepreventionline.org, the National Suicide Prevention Lifeline, Suicide Prevention Resource Center, and then also NAMI. So the National Alliance of the Mentally Ill, they have some resources there too. The American Psychiatric Association has some resources. And so that's about it. I want to thank you very much for your attention. Remember the code words that I gave you during this talk so you can get CMA credit. And if you need to get in touch with me, I am the Chief Executive Officer of Orbit Health Telepsychiatry, and I can be reached at edward@orbithealth.com, or you can go to the website, which is orbithealth.com. Okay, so thank you very much, and I look forward to seeing you in Las Vegas.